This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. And I'm joined this week, as I always am, by Dr. David Henry. Welcome to the 66th episode of Blood and Cancer. And Dr. Henry, it feels like one of those news update flashes, day whatever of the pandemic. And it just seems like every day, for those of us that work from home and are doing telemedicine stuff, it feels like every day is Tuesday. And for those of you that are in the hospitals and on the front lines, I feel like it must feel like every day is D-Day.
Well, it really does. For first few weeks, I'd wake up and thinking, oh, what's wrong? Oh, yes, it's this thing going on. And when will it be over? And it's becoming, sadly, the new normal, seeing patients with preparation of gown, mask, glove. The MAs in between visits in the office have to wipe down certain aspects of the room. Patients have to sit 6 feet away from me. They're only allowed to come by themselves, rarely with someone else, unless it's absolutely necessary, just to keep all this social distancing down to a minimum of interaction with people and closeness.
Yeah, and we see in popular media all the time, the conversation in sports is when will sports be back? What about concerts? And we have a presidential general election coming up. A lot of questions remain to be answered. Quick update, Dr. Alana Yurkowitz will not be here for the foreseeable future. Of course, she's in Northern California, very much affected by COVID-19, and so she's got to prioritize. But we will, at popular demand, we are looking into republishing some of her older work, and we might have to do that. Some of her stuff is so poignant, of course. But our guest this week you guys got into how his hospital is responding to this and sort of the comparison and what you're doing similarly and what you're doing differently between Portland, Oregon and Philadelphia, Pennsylvania.
Yeah, Dr. Lonergan at the Willamette Medical Center, where he's chief medical officer, was very interesting in how they're addressing this. And things I just mentioned, they're always doing and trying to decrease in every way staff exposure, as many people off site as possible. They're using telehealth all the time, as we all are. I'm at Penn, and they keep publishing daily statistics, and we're into the thousands of whether it's telephone telehealth or televideo telehealth, doing it all day long. Of course, not always at the office. They're trying to keep us out, just like Dr. Lonergan's doing in his discussion of what they're doing at the Willamette Medical Center. And he gets into what else? So the rest of your life need to continue research, teaching, tumor boards. I find actually some of the tumor boards, as we discussed, are possibly even more interesting because you sit at your computer and up goes the slide that's the pathology. And then up goes the mammogram for the breast cancer tumor board. And then the discussion. Now, of course, you can't see anybody. A few people decide to chime in by video, most by phone. And you never quite know who's speaking next. And sometimes 2 or 3 people speak at once because you can't see each other. But otherwise, it's fairly good discussions, when it's happening. I think one of the next things we might do is record it. So what if you couldn't attend and your case was discussed and then you could listen to it? So he gets into all of that face-to-face, dial down, decreasing staff exposure, social distancing patients. And then what about the telehealth use for research and teaching and tumor boards? Most interesting.
Yeah, I think obviously all of that's going to become part of our daily lives. I have 2 quick points for you to consider. The first is that you and I have been doing this together now. This is our 66th episode. We've been doing the intro together for, if I had to guess, around 30 or more of those episodes, about half or so. Yeah. And one observation that I had is the first time that we were able to physically meet, which is, I want to say, it was a while ago. We met in your office in Philadelphia. It advanced our relationship to the point where now that we do this virtually, because we have that building block, it improves our ability to kind of go back and forth, which is obviously a good thing. And I want to ask if that is similar in patient care, where if you had established a patient because you know how they are and you can talk to them and you've talked to them previously, does it kind of carry over and improve? And is there a risk that if you start seeing someone that was just referred only virtually, is that something that's kind of difficult to kind of adjust
to? It's such a good question. So on the past few days, I've done a couple of new patients. So we're being asked for new patients to try always to do video. So for that exact reason, you get to see each other, watch the body language. Are you sad, happy? How are you handling it? You can have a significant other, as happened today, a new small cell lung cancer patient, what he calls his assistant, which is his wife in the background chiming in with questions. She didn't want to be on camera. And we established pretty quickly a nice relationship. It was this 30-minute interview, all except for laying on of hands, all things medical to get through his case and then explain. He can see me. Many of, as our oncology audience knows, you have to describe what you're thinking. So where is the tumor in the liver? I draw a little diagram, say here's your abdomen, here's the liver, here's a spot in it. And then people can visualize what you're visualizing and not just assume they can. And then you talk about the therapy. Well, if you're going to get this chemotherapy, I write down the names and the frequency. It's every 3 weeks. And I write that down on paper. And so I'm just showing him, as we talked today about this new diagnosis for this small cell lung cancer, about what it looks like if I draw a diagram and what his therapy entails and how often he'd be in the office, so forth. So to your point, it's nicer if I have an ongoing relationship with a patient, but brand new with the video works. Of course, it begs the question, who is the audience? Are they always able to telehealth video?
Sure.
Not always have a camera, and not always have a computer, or not always have internet. So I think that's unfortunate because we're going to kind of differentiate who can do that and who can't.
Yeah, absolutely. And I mean, I tend to be a little hyperbolous, which is something that people in media tend to be, but we're getting to the point where financially, as a species, having access to the internet maybe should be a constitutional right one of these days, just because we're seeing this this is across medicine. We just did a podcast in dermatology where I can't look at what's on your skin right now if you don't have the internet, and I mean, it's not your fault that you don't have the internet. We see this in sports and news where everybody broadcasts to the 3 major networks because they can get them on their rabbit ears, and so we have to be cognizant of that specifically in these times. So my last question regarding this for you is, do you think that this pandemic has maybe jump-started your interest or anyone else's interest in maybe doing more telemedicine after everything calms down?
Yeah. On the heels of your first part, there's FaceTime. So to most people, I'm just shocked at how many people, no matter what their socioeconomic status, have the phone, and usually the smartphone. So you can do that by FaceTime as a last resort. And also, one more thing in the office happened to me a lot today. Only one person, only the patient, but putting the rest of the family or spouse on the FaceTime or just on the cell phone brings them into the conversation. Will this change things? I think it will. I think this is going to be changing a lot of things. So we're speaking in particular about medicine. It's faster, easier, less travel, especially if there are areas where people have to come from long distance. So I think this may well be a semi-new normal to a lesser extent, going forward. And speaking of going forward, an unusual graphic shown just the other day in these daily updates we get. So the Spanish flu, about the only thing we have to compare. Back in 1918, it came out and surged and caught the world by surprise in the early part of the year, like March. And there was that peak, and then it goes away. And then there's a bigger peak and bigger surge as we all huddle together again come the fall season, when we're all close together again, and still the herd, the term the IID specialists use, of all of us susceptible, it rages through there again. So it only went away when so many people died or so many people got immune. This time around, I think they're working as fast as possible. Dr. Fauci was even on the TV tonight. We're talking to you in mid-April, recording this, about the headlong work into vaccine manufacturer that 6 months minimum, 18 months more likely. So that's what's going to be happening. And in between those times, either you're immune by infection or immune by vaccine. We'll have to have a new normal. When will be the next time we can all go to an NFL football game? Is that going to work this fall? Can you go to the theater? Can you go to a restaurant? I think this social distancing will happen, sadly, for quite some time.
Yeah, and I foresee that as well. I'm obviously, I started my career in sports media, and have a lot of mentors that are still there, and so I've been discussing with them and kind of exchanging information about, because I'm very fortunate that I work in medical media and I kind of have my finger on the pulse, and I'm trying to tell them that this is, as far as a virus goes, I mean, this is not in the same breath as something, in my opinion, is HIV or anything that was like the bubonic plague. Those viruses, Ebola, the way that one dies from Ebola is extremely graphic. But because it's so contagious, because there are 7 to 8 billion humans alive, it has adapted to become so contagious that it's not something that is going to be like a light switch where Germany surrenders. This is going to be part of our lives for quite some time. And once everything is switched back on, I keep reading and we keep publishing stories about, COVID is something that is going to be part of the nomenclature of being a human now.
Well, human, I was just about to say the demographics. The Legionnaires, they marched down Broad Street in Philadelphia as Legionnaires. HIV, there was a certain demographic, and we know how to get it by needles or by unprotected sexual relations. But here, you get it because you're a human with lungs and breathing, and mucous membranes, and that's all of us. So, going around a while.
Yeah, absolutely.
I should mention, visit us on our webpage if you get a little tired of COVID-19, we have some wonderful oncology, hematology in our archive, mdedge.com/hematology-oncology, where you can hear this and show notes and others in the past. And also to give a little highlight, we're recording a little later this week an interview with some researchers, in particular colorectal cancer in the UK. And how are they in their medical system? And in the COVID era, how are they practicing colorectal cancer in the adjuvant and metastatic setting? Should be a most interesting interview. That'll be probably airing next week.
Yeah, absolutely. And I wanted to say something along those lines. We understand that we're a media outlet and we have to cover COVID. This is a once in a century event. However, we understand that hematology and oncology rages on, and that that's why our audience is here. We have non-COVID things in the pipeline, including what's going to happen at ASCO. Is it going to be a virtual meeting? We still are going to drop our part 2 of Tech Tools for Doctors, which is the better part. Part 2 has got some really cool stuff that even me as a tech nerd did not know about. We're going to get into breast cancer in May. We're going to do a nutrition conversation that's coming up in May as well. So we're gonna get off of the COVID thing soon, but while it's still fresh and raging in our veins, we have to understand how this is going to impact the field of hematology and oncology. And with that, this is probably one of the more poignant interviews we've done on the topic with Dr. Lonergan.
Welcome to this podcast. I'm Dr. David Henry, your host. You're listening to our Blood and Cancer podcast, which airs every Thursday morning, iTunes, or wherever you obtain your podcasts from. And we try and come to you each week with some interesting issues in blood and cancer and our specialty of hematology and oncology. We're also an online journal at mdedge.com/hematology-oncology. And of course, in this COVID epidemic time, there have been each week issues covering not only hematology and oncology, but of course, how does it change our practice of those specialties in this time of this terrible epidemic? And I'm delighted to be speaking this week with Dr. Matthew Lonergan, who is Chief Medical Officer, CMO, Willamette Valley Cancer Institute. And as he's told me, he's in Eugene, Oregon, home of the Ducks. And so, Matt, welcome to this podcast. Thanks for taking the time to join us.
The only thing that I have to tell you is that in Oregon, we pronounce it Willamette. The people here will get quite sensitive to the Willamette.
Oh, sure. Well, I beg your pardon, Willamette. So what we want to do then, of course, is ask you about how life has changed and take a little bit of your expertise in practicing hematology and oncology. But tell me, how has it changed for you? Let's discuss inpatient, outpatient, and teaching. So I want to take those one at a time. Hang on one second.
Don't worry.
Nick will get rid of the other line. My wife, South Philly Italian, is on the phone all the time. Let me see if I can silence that.
Just, from a personal standpoint, that is what I think is most amusing about all the telecommunication is the fact that it's completely acceptable to have your child walk in on you during an important business meeting or another phone call. It's totally normal today.
Well, in the evening news happens all the time. Why is that? Okay, it stopped. All right, so let me take a pause and then we pick back up. And I'll do that little let's talk thing again.
Okay.
So Matt, how are things with you there in Oregon? How has it changed what you do inpatient? Are you going to the hospital more or less? Outpatient practice, and then we'll get to teaching. So take it away.
Well, we started, we call it arcing, which is basically preventing physicians and staff from going to more than one place from an epidemiological standpoint to minimize our exposure. So we used to have a system where we would round in the morning, come to clinic, go to one office, maybe go to another office. And that's all stopped. Basically, we now have one person who rounds for the entire week, one person who rounds on the weekend, and you are allowed to go to one clinic site, and then you either telemedicine from home or off-site, or you support another site. But I think the biggest change has been this compartmentalization of your day that is normally built on 3 different sites or 2 different sites of practice or whatever, to a single site of practice, monolithically only. And then you have to sort of learn how to communicate with those other sites through your partners.
Now, are there certain days, in my own experience, I'm asked to be off-site 2 out of 5 business days, and in the office doing either patients have to be seen for chemotherapy or some telehealth or both, only 3 days. So in your group, are there similar dial downs on actually showing up?
That's correct. Yeah, we have asked every physician to be out 1 week at a time. Just sort of knowing the natural history of COVID and the incubation period, we kind of feel like that's the safest way to do it. So basically, we are all offsite 1 week out of every 3.
Okay. How many in your group?
We're, including all the sites, we're about 14 med-oncs, 4 rad-oncs, and 3 gyn-oncs.
Okay, interesting. Okay. So how about you personally? Are you seeing, what changes are you seeing? How difficult or easy is it? And what are you using to communicate with patients? Of course, the phone for the telehealth, I guess, audio, and then what do you do for video?
So we were a little slow to adopt a video platform. Even though the guidelines were basically, you can do whatever you want, don't worry about HIPAA. We took a fairly deliberate approach, and we're using a product called VC, which we were using in other practices that were related to us through USON. We're using for telemedicine for genetic counseling. So we had some experience with that platform. So we're using a platform called VC. It's only been up and running for about a week, so we are late to the telemedicine game. For the last 4 weeks or so, we have been doing a lot of phone call visits, and they don't pay enough to even warrant billing for. So we basically have just opted to do telemedicine. Fortunately or unfortunately, we have patients that have to be seen. So I would say volumes for most of the medical oncologists are down 60%, but still 40% of the volume are people that require treatment either for adjuvant or metastatic disease. And so they're in clinic, they have labs, they need therapy. So I think we're probably down 40 to 50% in our total number of visits for the last month or so.
Yeah, and that's the same with us. When I go in, I'm at Pennsylvania Hospital in Philadelphia. And so as a senior clinician, I've been asked to stay away from the hospital so I'm not infected / one of those who might get sicker. So it's very nice of my younger partners to pick up that slack. I try and pick up there for the excess that they can't do in the office or the telehealth. As I walk into the office building, which is a block away in our cancer center, my temperature is taken, which I guess is the quick down and dirty way of seeing if I'm okay, and then I'm turned away if I have a temperature. And we've been using the platform called Blue Jeans, is what Penn is requiring. Others and friends are using is Zoom. And one you might try with your partners is one I just heard about. Jitsi, JITSI, is supposedly HIPAA compliant, which Zoom I'm not sure is, but of course they're scrambling to make sure it is because it's so common now that's used by healthcare professionals. This Jitsi might be another good one. And it fairly, when it's the other side, the patient has the video capabilities, I do that. In fact, we required all new patients, if at all possible, they want us to see the patient visually. So those are video healths. Are you doing anything differently with new or old patients whom you're not sure, like you have a new metastatic lung cancer that is referred to you? Do you see that patient online or in person first visit?
We didn't conceive of the possibility of seeing new patients originally by video, but once we started doing it, we realized that there were certain clinical circumstances, like for medical oncology, an adjuvant breast cancer patient who's already had surgery and has pathology, and we're going to send some kind of molecular test to risk stratify them for adjuvant therapy. Actually, those conversations don't really require a physical exam that much.
Yeah.
So we have started doing new patients that way. We started conceiving of the video platform for our established patients, not our older patients. But we live in an area that's a little more rural, and I'm sure that cities have the same problem. I've been surprised at the number of people that don't have internet access to allow video capability to work in any functional way. And, some patients we've tried, and they literally end up calling me from their front porch where they can get cell service, because that's the best we can do. So I think probably 10 or 15% of the time, internet access becomes absolutely impossible. And then probably 10 or 15% of the time, equipment failures. Somebody's using their son's PC from their previous work from 27 years ago and doesn't know how to install the appropriate software. But I think it's easier for the people who live in the city of Eugene. But as we move farther out, the technology gets more challenging for people.
This has been surprising to me as well, although if you stop and think about it, I guess it shouldn't be. That's exactly right. The evening news has said that as so much communication now needs to occur online or with sophisticated computer access desktop or laptop, not everybody has that, either the machinery or the internet availability. An amazing anecdotal statistic of which is I have a patient who works in one of the local like Best Buy micro centers here in Philadelphia, and I see him weekly, and he said here they're doing a land office, unbelievable business on the weekends, selling equipment, laptops and desktops, so that people can gear up in this new era.
We had trouble when we were sending. We relatively early tried to send a lot of our employees home. We tried to minimize, especially in the business office. And one of the problems we had was, even with our own employees, simple things like a lot of people didn't have a laptop that they could dedicate to work that was capable of doing the Citrix receiver thing to look at their desktop at work that was safe and things like that. And so I went to Best Buy, of all places, to try and buy a couple of Chromebooks, and they were sold out.
Yeah.
And it's just funny how really simple things like wireless hubs, cheap, inexpensive web browsing computers that can do Citrix, how very basic equipment is hard to get, as is toilet paper and water sometimes.
Yeah, exactly. And actually, it occurs to me as we're talking, our listeners, I invite you to give us your tips and clues and surprises you've found and how to work around this system. Again, our webpage, mdedge.com/hematology-oncology. Please comment what you found or what you want to modify or change what we're saying. How about, of course, in a group like yours, like ours, we try and stay up to date, which is increasingly difficult as hematology oncology has so much bench to bedside. I think we counted 19 new FDA approvals last week for medications for us, or new labels on drugs already out. How are you managing a teaching function? I'm sure you had some tumor boards or discussions with partners. What's changed? What's different about that now?
Well, so we do we have several people in our group who do a fair bit of research, and so they have always served as sort of the de facto lymphoma, myeloma people that teach us by simply asking, "Hey, I got this new guy who's 67 with a bad myeloma. What would you do?" kind of a thing. Mm-hmm. And that function has stayed pretty much the same, because we used to call those people anyways. The difference is we would call them driving home, as opposed to when they're in the office next door and stand outside and dwell. Asking them questions. The other component, as far as like tumor boards and things like that, our hospitals have made the switch to a Skype platform for virtual tumor boards, and I actually kind of like it better.
I agree completely.
I'm surprised. I know there's a value about the in-person tumor board, but I find it easier to see the images, to deal with distractions, and I can also meet the on-site presence rules that are always a problem for billing, to show up at clinic at 7 because of extended hours. it's hard to go to both the tumor board and be here at 7 o'clock. So it's been actually easier, especially with less staff, to meet all those legal requirements. And I actually really enjoy the online tumor board as much as the in-person.
I agree with you completely. I was on our breast cancer tumor board 2 days ago, Tuesday, and the images come up, the pathology comes up. You can see you can even see many of them, or certainly hear many of them. It tells you who's talking. We get a lot done. That your mention of research reminds me to ask you how that's changed. Again, I'm at Penn, and they have made a system-wide requirement that no new studies will open and no open studies will accrue. The problem being, resource allocation. They're just worried because all our research staff are off-site now. They're telehealthing in. How has it changed your researching function? What are you doing about that?
With the exception of pharmacokinetic studies where, research staff has to be there that are pre-existing, we have minimized the research staff. I hardly ever see them except for passing in the parking lot. They're in a separate building. They will come into the clinic only when absolutely required. We're delaying or not actively enrolling in a lot of the registry type trials, but the critically important research trials, that are required for hematological malignancies and things like that, those are still going on, but at a reduced rate. And so there's no formal rule, but our research director, Dr. Sharman, has kind of asked us to be thoughtful stewards of the research staff and also the risk of infection and also our patients. And we've sort of obliged in a general sense. And I don't think our enrollments are certainly down substantially, but I think that those people that you need, that really need those unique treatments that are available, they're still available. It's just we have to be very thoughtful about whether that's appropriate or not.
Yeah, and that reminded me back to teaching function, or I guess it's both teaching and research. We had a weekly journal club, and of course we'd all sit together in a conference room. Our providers, whether they be the physicians or the nurse practitioners, PAs, everybody would come and try to have a lunch, which tends to bring everybody. So of course that stopped. So I found an option which we used this past Tuesday with some success. There's these online, you probably get them in your email all the time, I'm sure our listeners do, from various CME, yes or no organizations to say, here's an update on CLL and Dr. So-and-so is talking about it. Popular ones, and the one we used this past week worked really well. VMedi, that's VMEDI, VMedi. Then there's PER, Physicians Education Resource. And then WebMD, full disclosure, that's our parent company for this podcast, WebMD, all do that. And you can listen to a nice lecture by a thought leader. So we've tried to keep our journal clubs up instead of me droning on about the most recent article in Blood. Now we can actually have a nice lecture from a key opinion leader online. Have you done anything like that yet?
No, we have not. I mean, I think the only literature that we have read in the last month, except for the people that are doing a lot of research or have disease-specific practices, everything has been sort of focused on COVID. So it's a New England Journal paper about COVID or about the spread of the disease. And so I think in many ways, all of that has sort of stopped. And then all of the meetings that we have that we would go to locally or regionally for education, those have all stopped. And I've attended a couple of them virtually and found it actually very efficient. And so I think as the platforms for off-site meetings occur like this and they become more sophisticated, that may be my preferred way of doing things, to be a little antisocial compared to how I used to be, because I just find it very efficient, especially if I can choose to listen at my own time and place.
Well, it really is true. Yeah. Except, just as you said, except for the lack of social, I would go to ASH and ASCO, which sadly ASCO's going for this year, and I would actually go to the updates afterwards, because you get together in those updates after each major meeting of 200 people, and they bring the presenters to you. And so you get to hear them and you get to talk with colleagues over lunch. In fact, you can go to different lunch tables and have the specialists on CLL or hemophilia or myeloma. And that disappears, but otherwise at your leisure, when you can, you get a really nice lecture from whomever.
Yeah, I miss the questions. I often find that's the one thing that's different about the video conferencing and things like that, or especially when you're on a delay, is that there's always somebody in the audience or even a small group who asks a question or asks what you would do in this circumstance. And I often find that's the one thing I miss about the distance platforms is those questions that really pose interesting and subtle questions that I find that where I learn the most, and those are lacking a little bit.
I'm just checking the reference. I'll have to put it on the webpage. You mentioned the New England Journal. I think it was beginning of April or end of March. A perspective, beautifully written perspective on what's happening now and how this is a couple things. No great surprise. 1918, the Spanish flu, which actually didn't originate in Spain, they were just the first to report it, killed 50 million people. And what we have 100 years later, perhaps better, is supportive care. I'm sure we have better supportive care, but no therapy, although they're working on vaccines. And the authors went through then and now and how it's just going to keep happening. We, unless you're quite senior, even I'm not senior enough to remember that. I remember standing in line getting my sugar cube for the Salk vaccine, and polio went away, but it was an annual summertime experience that people would go paralyzed or die, typically children, when polio was around. And so while we're better, certainly supportive care, these epidemics will keep happening. So I encourage our listeners maybe to read that on the New England Journal perspective, end of March or beginning of April. So it's unfortunately happening unbelievably worldwide, but maybe we're better able to handle it and hopefully prevent it with vaccine.
It's funny you mentioned the Spanish flu, because when I trained in medical school during the HIV epidemic, and it was interesting because it didn't have the same fear that this has in the community, and didn't cause a significant social change compared to COVID. But we would have pizza once every quarter or so with some senior physicians. And at that time, this will tell how old I am, we were talking about the HIV epidemic with a physician who actually trained during the Spanish flu. And
really?
he said, the fear, I understand, it was terrifying, but you understand when there's fear in the medical community and fear in society. And he said that was the one he remembered. He also mentioned polio. He said that was different. Most of the providers weren't afraid of polio, right? But society was terrified of polio. But he said Spanish flu, and that's what this feels like, although I wasn't alive during the Spanish flu. I think this is different than anything I've ever experienced. And I remember that conversation that we had when I was a first-year medical student, because we were talking about, well, what's going to happen when I'm on phlebotomy duty at the VA drawing blood? What happens if I stick? And there were no antiretrovirals, and it was irrationally fearful. You know what I mean? The risk was minimal in reality, but it didn't make it any less fearful. And I remember him sort of saying, look, this is nothing compared to the things that people have dealt with in the past. And it sort of came back to haunt me the last few weeks going through this whole process, to remember that we have been through this before.
Agree. I shared your experience of the HIV. No one knew what it was, and initially weren't sure how to get it and how contagious, by touch or by breathing. That became clear pretty quick. And this now, of course, is a really silent, invisible killer. Breathing somebody's air, if it stays around for a few minutes in the air and you go through it and breathe it, or of course your hands. I did an experiment on myself a Friday ago, watching where my hands go as I'm just going through my daily day, and you touch everything. And then of course it can't infect your hands. It has to get into your face. Of course, you touch your face. For our listeners, I found that perspective is really enjoyable to read. It's called Escaping Pandora's Box, Another Novel Coronavirus. It's in the April 2 New England Journal perspective. The lead author, Dr. Morens, Morens, Escaping Pandora's Box. Well, anything else you wanted to mention about your experience? I think we've covered inpatient, outpatient, the change in our lives electronically, and teaching and research. Anything we didn't cover you want to mention?
Well, I think one of the fun and interesting things about being in private practice is we're a small practice, and we're not supported by, I'm not expecting the federal government or the state to help us out necessarily. We kind of live on this edge where we're kind of on our own. And it's been really interesting, the supply and logistics to how to keep a practice open and running. I spend most of my time trying to figure out how I can get another 200 masks here or there, or how I can get personal protective equipment, how I can get water. I'm just surprised we had this mandate that we, appropriately so, that we monitor every staff member's temperature.
Mm-hmm.
And they do it twice a day at home. And we also do it when they walk in the door, as we do for every person who walks in the door.
Yeah.
All of a sudden, I need 250 thermometers. I can't find, you would think that, you have 250 employees. It turns out a lot of them don't have thermometers. And all of a sudden you're trying to find, and you can't find thermometers. And so I find it's interesting, the things that you don't initially anticipate, sure, mask or gowns or something like that. But it's these little things that make your daily operations compliant and efficient that you can't find, that really you spend a disproportionate amount of time dealing with. And I think that's been the one surprise for me about how things like toilet paper, thermometers, there aren't enough of them to do the very most basic things.
Yes, and I couldn't agree more. And the only other thing I would add is we needed to go a little bit shopping, even despite many deliveries to the house, which were helpful, but we had to go to a store. And so I stayed in the car. My wife went in with masks and gloves, and she was shocked. She was in and out quickly. How many people, no mask, talking and walking together. And I don't think it's quite hit everybody. Of course, we're medical, we're very aware, but it hasn't quite everyone how important it is to do exactly what you're told and avoid being, we're in the shadow of New York here. And so we're very aware, I think, in Philadelphia, although here in the Philadelphia suburbs this past weekend, in and out of the food store, not everyone was quite so aware. Do you think the public uptake there in Eugene is similar to what you understand as being a physician?
I think there was a big change. I think I noticed it last weekend when the CDC guidelines came out talking about it's okay to wear a mask, right? Yeah. And I was in the same store on a Friday trying to get cleaning supplies for the clinic, and that same store on Sunday. And in 2 days, I would say we went from 5% or 10% people being masked to 80% of the people wearing masks. And we have a wonderful community that's, people like sewing brigades that you wouldn't imagine. And, our patients come out, but they don't necessarily have contact with people that can provide them with a mask. We've given away hundreds of masks to patients that our community has donated. So, but I think there was a real change. We social distanced relatively early because of state mandate. I think, I don't know exactly when it was, but I think we've been, schools have been closed and distanced since mid-March. And so people were pretty good with that. But I think once the CDC said wear a mask, it kind of it put a face, for lack of a better word, on the whole problem. Yeah. And I think that everyone sort of realized that it was okay to try and look at somebody a little bit funny when they were 2 feet away from you. And it wasn't being rude. It was just reminding people that we need to do this. But I've noticed a big change in behavior here in the last week after the CDC guidelines changed.
Well, it sounds like, fortunately, the message is getting out, and I think that we're going to peak pretty soon, we hope, and start to go on the downside. Well, Matt, I want to thank you very much for taking the time to talk with us today. We were speaking with Dr. Matthew Lonergan, Chief Medical Officer at the Willamette Valley Cancer Institute in Eugene, Oregon. Matt, really thanks so much for taking the time to talk with us. Really appreciate it.
Well, thank you.
By reminding our listeners that this has been Blood and Cancer Podcast. You can hear us and look at this and previous shows at our webpage, mdedge.com/hematology-oncology. And we thank you very much for listening. Please comment if you have suggestions or comments about how we all do this in the COVID era. We'd love to hear them. Thanks again.